workforce development in Ethiopia. Bonjour à tous et bienvenue à ce webinaire sur le développement du personnel de santé en Éthiopie. Alors, avant qu'on commence, je voudrais vous inviter à rejoindre votre bout d'internet.
Before we start, please go to the right language. I think most of you already know how to use the system, but there's a small button on your right where you can choose the language you want.
Invite you to join the interpretation booth. I'm sure you're well aware of how this works, but should this not be the case, you can join it by clicking on the little button where it's written talk, interpretation, excuse me, that was my language in Dutch. So you can just join interpretation and go to the booth of your preferable language. I am very happy to have you all here again. I would also like to ask you to rename yourself. Should you have any questions during this conversation, during this webinar, please do not hesitate to use the chat box. And yes, as I said, where are you joining from? It would be great to hear that. I see some things are already being shared in the chat. And before we start, I would also like to ask you just a quick question on what your expectations are for this webinar. So a word, a quick sentence. So I'm going to count to 3, and then you can just share it in the chat. 1, 2, 3, go. What are your expectations for this webinar? Can be a word. Dr. Kobina, bonjour à tous. Apprendre des autres, to learn from others and from each other. Yes. What else? Hello, Morbe. Bonjour, bonjour. To learn the experience from Ethiopia and others. Thank you so much for sharing, Petron. And maybe a last one. Esther, thank you. To learn from others. Very important. Exactly. And that's what we're going to do today. So without further ado, I would like to hand it over to Dinxera, who will give us a brief context of today's webinar. The floor is yours, Dinxera.
Thank you, Amy. Hello, everyone. It's nice to see you all again here. I think this is our first gathering after our retreat, and I'm very happy that we could start with this session. So before going to the presentation, I would like to say a few words on why we chose this topic for our webinar today. So the health sector is essentially about people and the vital role of the health workforce in providing quality health care for the population health, especially for RMNHN service, is very important. So without health workers, there can be no health care. And this has also been recognized in various UN, WHO, and International Labour Organization documents over times. And accordingly, various commitments and attempts has been made to attain the universal health coverage and also the sustainable development goals. And Ethiopia, as one of the countries who has made this commitment, has implemented a stepwise expansion in the enrollment and training of various health science disciplines to build a strong primary healthcare system. And the health sector has done this with the Ministry of Higher Education, which has been successfully put into practice and also assisted our country in making great stride toward solving the most pressing health issues. However, the economic growth, the rapid urbanization, and the change in the lifestyle, what we call the triple burden of disease, like the non-communicable disease, the injury and trauma, and the communicable disease. The country still face difficulties in recruiting, in deploying and retaining enough and well-trained and motivated health workers. And this called for a strong HRH planning. So the strategy was developed in 2016 to address this existing and emerging problems. And despite the improvement following the implementation of the strategies, there still exists a challenge because the human resource for health agenda is complex, and there are many actors involved. Therefore, we believe that exchanging experiences enable us to keep an eye on the key drivers that will help us improve the development, management, and also the regulation of these human resource strategies. And it also will enable us to identify the cross-sectional issues and help us develop policy recommendations in the future. And finally, I would like to mention the JFF operational plan that was prepared for the IG meetings after Minister of Health have emphasized the challenges and constraints that they face to finance their existing health workforce during one of the IG meetings. And this document gives a brief situation analysis, and it gives a good recommended strategic actions. If you are interested, it will be shared with the recording and other materials. With this, I will give the mic to Asagid. Asagid, the titles have been changed recently, so I need to refer to my note. Asagid is the lead executive officer of the Human Resource for Health Development and Improvement lead executive officer in the Ministry of Health. He will be leading us through the development and implementation of HRH strategy in Ethiopia. So Asagid, the floor is yours.
Thank you, Isra. Good morning, good afternoon, everyone.
Sigit,
Can
before I give you back the floor, sorry. So for everyone who is in the interpretation booth, you can see the French version of the PowerPoint within your interpretation booth. So you don't have to follow this one, but you can follow immediately the one in French. Sorry, Sigit, just wanted to point that out. Thank you.
No, it's
Floor is
okay.
yours.
Thanks so much. Thanks so much. Good afternoon once again. Thank you, Isra, for the introduction. So this is a second. I'm working as lead executive officer for the Human Resource Development and Improvement Office in the ministry. So I'm very happy to share with you how we did the Human Resource for Health strategic plan in the past 5-6 years. So my presentation outline will be like this. I will take you through the rationale why we designed the human resource for health strategy, what are the major components included, how the major implementation looks like, the lessons, opportunities, and way forward will be included in my presentation. So to begin with, it's obvious that countries are, planning different kinds of initiatives to meet the health sector needs and the needs of the people, especially in the health services. So when we consider all these issues, the backbone is the workforce. Unless we have a strong workforce, it will be very difficult to have a resilient health system. So workforce is a backbone for a strong health system. Even if we design different kinds of strategies, different kinds of initiatives, unless we have a strong workforce, it will be very difficult to achieve the mission of the institution. Beyond that one, the country, not only Ethiopia, but all other countries have planned to meet different kinds of global commitments, SDG, universal health coverage, and others. So, in order to meet all the requirements described in these global commitments, the workforce is a very crucial agenda. So, investing in workforce has a good return outcome. And the other thing is actually it's not only meeting the global requirements, but also when we consider the access and the quality of workforce is also very important in order to avoid things. And beyond that, workforce is very important. So with this in mind, in Ethiopia, there are lots of improvements in workforce development. Just to take you back, the last 5 years data, as you see from the graph, there is an increment in workforce number. This is, due to, high investment in workforce. So with this, the progress, the workforce density to population, the health professionals skill mix, the geographic distribution, has made a tremendous increment in the past 5 years. So this is just to give you, a background on our workforce data. So how we need with the strategy, as Isra explained, our strategic plan started in 2050, 2060, and will end in 2025. So why we need this strategy as a country is a very important question. In the first case is we don't have a strategic document which will help us to guide the workforce development management in our country. This is the first priority. The other thing is the commitments are there, but we don't have, the roadmap. We don't have the ways, to achieve the activities stated in different kinds of commitments in our context. The other thing is there are different kinds of initiatives, different kinds of reforms are coming, coming in here and there, but there is no way, there is no guidance, to achieve these things in a coordinated manner. The other important thing is workforce is, a cross-cutting issue. It requires the involvement of, multi-sectoral engagement, intersectoral engagement is a very important aspect. So in order to clearly identify, to clearly, outline the roles and responsibilities of different kinds of sectors is very important. So this document, this guide helps us to know what do we expect from the regions, Ministry of Education, and all other actors in achieving the strategic actions in our strategic plan. Some of the global issues are also there. So we do highlight it, we do give a due consideration for the workforce development. That's why this strategy is needed in our context. So when we designed this, the human resources for health strategic plan, different stakeholders was involved. Minister of Health are the major stakeholder because we are there to determine, to disclose our demands. So the Minister of Health, is a major stakeholder. Minister of Education, especially for pre-service education training, majority of the workforce production is happening in universities. Universities are accountable to Ministry of Education. So the Ministry of Education is also there. The higher education relevance quality authority, because quality is it's not only workforce production, but quality must be in place. So the HERCA is there, the different agencies in our country, the regulatories, the federal, the food and drug authorities, the Ethiopian Public Health Institutes, all the stakeholders mentioned here have their own roles and responsibilities in the designing and developing the human resource for health strategic plan in our country. So with this in mind, the vision was actually a bit different from, the vision statement is highlighted in various documents. Our need, it's not only felt need, but, it's evidence-based. We want to have, adequate number of well-qualified health workforce. Ethiopia is a country having a critical workforce shortage based on, WHO recent evidences. So the document, envisions to have adequate and well-qualified workforce. The other one is, being compassionate, being respectful is very important to deliver services to our clients. So the strategy must envision to have a workforce to be compassionate, respectful, and caring. Contributing the health sector vision of Ethiopia. This is our vision. The strategic goal of the document is a bit, linked with a vision statement, but, mainly highlighted, ensuring the availability of well-qualified, adequate number of healthcare professionals. We need to have, appropriate skill mix, equitably distributed, motivated, retained, to achieve the needs of, the Ethiopian population and improving the health of the people. This is the strategic goal of the strategic plan. The strategic plan have, the following major components included in the strategy. So the strategy is highlighted in a way, having, major outcomes included in the strategy. The strategic objectives are also identified. The strategic actions, what are the specific activities, are also highlighted in the strategic plan. So having this, the strategic plan is organized in 4 major outcome areas. The first one is with human resource for health legislation, learning, and partnership. In order to begin any kind of activity related with human resource for health, the legislation is very important. We need to have a legal backup because workforce is, as I said earlier, the cross-cutting issue. Unless we have a legal backup, doing everything, this will be very challenging. In order even to enforce some of the activities highlighted in the strategic plan, there needs to be in place a proper legislation. So this is one of the outcome. The planning and partnership is also very important. It's very difficult, to work or to perform activities listed in the strategic plan by the Ministry of Health alone or Ministry of Education or some other partners. It requires the involvement of different actors, be it, partner, donor implementing, or other donor partners, Ministry of Education, regional, zonal, and different kinds of administrative structures are very important in workforce management, production, and regulation. So partnership is a very important concept in this strategic action plan. The other outcome is the workforce education and training capacity. By the way, I will give you some details on some of the strategic activities later, but what I'm just doing now is giving you a brief what the major outcomes, tried to clarify in the strategy. So the health workforce education and training is the second outcome. In order to achieve, especially the workforce number, investing in workforce education and training is very important. In our context, as I tried to show you in the first or second slide, there is a remarkable improvement in terms of number. But these days we are focusing on quality of education because, the progress made in increasing the number of workforces very nice, but evidence shows that quality is still challenging. For that, we have introduced different kinds of initiatives that I will explain in the upcoming slide. So investing in workforce, education and training is the second outcome, especially in the in-service trainings. The major focus highlighted in this outcome is, standardizing the in-service trainings and, beginning the continued professional development for our healthcare providers. The third strategic outcome is the human resource for health leadership, governance, and human resource management, practices are strengthened in all levels. Leadership here is a very important concept. All the activities that I have, talked earlier are related to leadership. If there is a strong leadership, there is a way that we can achieve our goals and plans. But if there is no strong leadership, it is very difficult to achieve our plans. The other thing is the leadership, strengths or capacity in all levels must be, uh, in a good manner, I can say, to achieve the goals. Most of the time in our country and in some of the countries, the leadership in federal or ministry level is very good. But when we go to down the administrative levels, the leadership capacity is very weak to lead the human resource development, management, in other human resource functions. So we need to have a strong leadership with who will, envision, uh, who will, see how they can better manage the workforce, they can better lead the workforce development and other activities. So the leadership is a very important concept. The last strategic outcome is the retention and the motivation issue. This part is the very difficult part, to work on because uh, retention and motivation are, the critical issues. It requires different kinds of, investment, especially if you ask any healthcare provider, there is no peculiar or specific way to motivate healthcare providers. But the country, we have designed different kinds of incentive, motivation, retention package beyond financial. We have also designed some other non-financial ways of motivating our healthcare providers. But when we compare with the demand, with the needs of the with the healthcare providers, it is far beyond. So this is a challenging area, but we are also trying to work in this aspect. The workforce performance is also very important. One of the challenge we have observed in the implementation of our strategies, there is incentive and motivation mechanism, but it's not clearly linked with performance. It is not identifying who is performing well and who is not performing well. So it's like, a gross implementation of retention and motivation, okay, that we have learned, to make revision in this aspect. So with this major strategic outcomes, the major strategic actions are, the following. I will not go to all the activities, but I will highlight, some of the critical activities. Uh, yeah, implementation of, different kinds of standards, guidelines, legislative frameworks are, the important aspects of this strategic plan, because it's only with these strategies that we can clearly, how we can work, how we can operate, how we can collaborate with different kinds of actors in human resource for a strategic plan. So this is the major strategic objective or direction included in the strategy. Data is very important because in order to determine the human resource need, demand, the requirement, data is very important. So we have tried actually established the human resource information system with all the challenges we are trying to work in this regard, but it's one of the activities we are working on. The other thing is our workforce. Oh, sorry. our workforce must be gender sensitive, gender responsive. There are some activities designed. This is the other activity, the improving quality of pre-service education and in-service training is also the other activity included in this important strategic plan. Quality, as I said, is one of the critical component of the strategic plan. So application is in place, licensing, uh, regulation of not only the healthcare providers, but the institutions must also be accredited. So we are working in that regard too. The other one is, improving the workforce recruitment, deployment is very important. There is some challenge in our context. The challenge is we are saying we are having shortage in human resources, but in the other context, we are not deploying the producer manpower. So always trying to work on improving the workforce recruitment, improving different kinds of models or opportunities to deploy healthcare professionals is very important. So it's part of the activity. Inequity, geographic inequity, it is one of the challenges, especially most of the professionals are in cities, but we don't have adequate professionals in hard to reach areas. So ensuring inequity is our major activity, motivation, and improving workforce productivity, performance, efficiencies. Parts of they are key components of the strategy plan. With this, I will try to give you, the major implementation progress, so far in some of selected activities. In human resources development and management, there is, I can say the government has invested a lot to expand the number of teaching institutions and programs. So this has contributed for improved workforce density in our context. So this is the first major progress we have made using the strategy. The graduation capacity, the enrollment rate has increased, increased in a good number. So our annual workforce production capacity per year, it includes all different kinds of health science disciplines. So we are producing nearly 20,000 healthcare providers annually per annum. So this is the good progress we have made in the past years. The other one is the continuing professional development. In our context, in-service trainings are, fragmented. We don't have a way, we don't have a modality to control all these types of trainings because in-service trainings, continuing professional development trainings, they are costly. We are investing a lot, but we are not investing as per our investment. So we have tried to standardize all these trainings. So continuing professional development is, part of license renewal. So when our professionals are planning to renew their license, they are expected to present CPD courses as a requirement for license renewal. The other one is the education roadmaps, specialty, subspecialty, different kinds of service roadmaps were also designed as part of this strategy. The partnership is also there, especially with the partners, the private sector, the professional associations are highly engaged in workforce development. Here, what I would like to highlight is we are now, at these days, we are investing in our health facilities because majority of the clinical discipline trainings are happened in healthcare facilities because clinical teachings are, practice-based. Professionals are expected to make practice in healthcare settings. So if we invest in, improving the clinical setup, meaning creating a conducive environment for students to practice in hospitals. If there is a reading corner, if there is adequate preceptors, skill labs are already there, it will, contribute to quality of training more than 60 to 70%. So we are seriously working in this aspect. The accreditation is also there. These are, some of the major achievements we have recorded in human resource development. In regulation, as I said, the legal documents are there. There are different kinds of legal documents and directives endorsed to have, which will help us to enforce our regulation capacity. We are also, following evidence-based approach for licensing. Yeah, yes, previously, the licensing mechanism was, it's only based on counting the service years, but these days we are trying to use different evidences to renew license. Licensure examinations also in place. So when students complete their education in universities, ministry will give a licensure exam. So those who pass the exam will have a license to practice in our healthcare setting. The licensure examination is mainly actually a competency-based testing, but these days we are also planning to include objectively structured clinical examination as part of the licensing examination. This is the major achievement in regulation. In human resource management, there is we have tried to improve the human resource management structure and capacity in all administrative levels. There is, improved practice, including recruitment, deployment, motivation, in designing both financial and non-financial incentive package, but it's also a very big challenge. Yeah, there is improved job evaluation and grading practices. So we have introduced a job evaluation because jobs must be evaluated in a way to support the activities in workplaces. So we have done this with Ministry of Civil Service Commission. So the human resource information system implementation is now, promising. We will make a robust investment in the upcoming years to improve the human resource information system. So uh, the cross-cutting issue, especially the political commitment in will is also increasing now. Human resource for health is, getting attention, in ministers and some, the political leaders. The collaboration is also there. It's also, a very good achievement. Different kinds of policies and strategies are, supporting the workforce development management, the labor market analysis that we have used, the workload staffing need assessment. These all evidence are, helping to have evidence-based workforce development in our country. So this is one of, the activities we have used as, evidence to determine the workforce projection in our setup. As I said earlier, the ministry, in collaboration with WHO, has done the health labor market analysis. We have also done the workload and staffing need assessment. Based on that one, we have determined the workforce requirements for the country. So this table shows how much health professionals we need in the upcoming years. So we have used different scenarios to determine the workforce requirements of the country. So these are, the major progress implementation updates on workforce development and the human resource for strategy in our context. So as I said, as an opportunity, the political will and commitment, engagement of the senior leadership is very good, which helps us, to have a good progress in some of the major activities. The workforce is one of the strategic, priorities in our health sector transformation plan 1 and 2. There is, different kinds of strategies supporting the workforce development. some of the global efforts. For example, Ethiopia was champion in HRH in the past World Health Assembly 74 to 75th. We were able to endorse Human Resource for Health Action Plan, Human Resource for Health Action Plan. So we are, working in that regard. So these efforts are really helping us to work more in workforce activities. The experience that I say, the labor market, the workload, staffing need assessment. Recently, we are working with WHO Afro on investment, workforce investment charter. So the expansion of facilities for better practice are, the major opportunities, but there are also, challenges as any country. There are, challenges which hinders workforce expansion, development, management in our country. The density is the challenge. The distribution, skill mix is the challenge. As I said earlier, the motivation and incentive package are also the major challenge. Yes, we are trying, to think differently how we can, contribute to motivate, incentivize the workforce, but it's really, resource intensive and it's challenging. So I will be looking forward if there is any experience in this aspect, to be considered in our context. The digital learning platform is not well developed. As I said earlier, we are expanding continuing professional development. Most of the trainings are, face-to-face, in-person trainings, but it's very difficult to address, the increasing number of workforce with face-to-face training. So we need to increase the e-learning modalities. We need to have, a well-structured e-learning platforms which will support the competency development of our healthcare workers. The stakeholders engagement is also, sometimes challenging. There's a good, but, sometimes we are not, actually the engagement is not as to the expected level. The collaboration is still challenge. The academic service integration is, the challenge because especially in our university hospitals, it is very difficult to align academic and service. So this challenge, exposes, challenges the actual service that our clients must, get in our hospitals. So this the other challenge. The workforce investment must be increased, and the CPD implementation is now still on progress. So moving forward, the strategies, under revision because there are lots of developments in our context, especially starting from the global development in human resource for health action plan, the global workforce strategy, and other issues. We are, exercising how we can incorporate, the major issues in our strategic plan. Uh, there needs to be improved investment in education and employment. Employment is a challenge. There is shortage, but because the fiscal capacity is very low, so we need to work more on improving employment opportunities. Especially beyond considering some of the donor funding, we need to internally see how we can work on domestic financing, building the capacity of human resource development, across the entire systems, not only, as I said, in ministry or in federal levels, but there needs to be a strong workforce management system across the entire system. The partnership must be strengthened more, supply and skill wise, especially in our healthcare facilities must be strengthened. And the evidence is also very important because we can only make improvement if we have adequate evidence. So we need to work more enhancing evidence generation, not only evidence generation, but also using them to inform our policy. So this is all from my side. I thank you very much for your attention. Amy, you are muted.
Thank you. I just wanted to thank you, Asigid, really for a wonderful presentation. I see Patron was already applauding you. So really very much thank you for this wonderful sharing of information. Um, so what do we want to do now in this part of the webinar? We would really like to ask you just to see if there are any questions, clarification questions. As I already have a few questions in the chat that I've translated as well. So I have a first one here, some clarifications asked from Morbe from Chad, our colleague here. So first of all, are all the staff trained in universities recruited by the government for public health facilities, or are they also recruited by the private sector? And the second one from Morbe would be, to date, are shortages of health personnel recorded in the peripheral areas or not? So maybe you can already answer that one. And then we'll go over
Thank
to
you. Yeah.
Fostan's questions later. Yes.
Yeah, thank you for the questions on the actually, the recruitment is not only happening in public health facilities. So all the staff trained in universities, they have got the opportunity to be recruited in any sector. But in the past nearly 4 or 5 years, because of the shortage we have in healthcare providers, the Ministry of Health took the responsibility to deploy the healthcare providers in all areas of the country. But now, due to physical capacity shortage, we let healthcare providers to find jobs by themselves. That's why we are, facing some challenge in, deploying some of the professionals. But all professionals trained in universities, they can be recruited anywhere in the country. So on the second question, most of the shortages are happening in peripheries, especially in areas in hard to reach areas. Because the infrastructure is not well developed. Most of the professionals are demanding, to have a place, some, fancy place, I can say. So because of these issues, the challenges are happening in, areas where they are, in rural areas. That's, the challenge we are, facing these days. But we are, discussing with regional health bureaus to address, to design a mechanism like, for example, those who are willing to work in hard to reach areas, they will be given an opportunity, career progression opportunities, scholarship opportunities, and some other, models. So these are, improving the workforce availability in rural areas. Thank you so much.
Thank you very much for clarifying that, Asigit. We have one more question here, two more questions from Fostan from the DRC, asking whether the strategy talks about, the strategy talks about all elements of the HR career management except for retirement. Why is that? Does this mean that over the course of 5 years, there have been no retirements of staff who have reached retirement age? And then the second question would be, what strategies have been put in place to encourage staff to work and stay in the rural area?
Amy, thank you again. The requirement is actually is part of the strategy, but it's not, well explained in the outcomes. But in the specific activities, the retirement, part of this strategy. But we did not highlight it as, a major strategic outcome. But now we are, revising the strategy, highlighting the retirement as one of the critical components of the strategy in order to motivate professionals to work in rural areas. as I, tried to explain earlier, now we are, seriously discussing with regional authorities, with the regional health bureaus, to have different kinds of modalities to support, motivate these professionals. The first one, as I said earlier, the service here is now, for example, a professional working in cities. They are expected to give service like equivalent to the learning period during the universities, meaning if he or she have took four years stay in the university, uh, and if they are, deployed in cities, they are expected to serve for 4 years. But if they are, deployed in rural areas, the service year will be shortened by half and something like that. The other one is they are getting scholarship opportunities, better scholarship opportunities, and some of the incentive and motivation packets are, a bit higher than those working in, cities. These are some of the mechanisms we are trying to introduce in our context. But regions are, mandated to design their own strategies based on the national strategies. So these are some of the things that we are trying to introduce to retain professionals in hard to reach areas. Thank you.
Thank you once again, Asigit. We have another one from Petrom, our colleague from Zimbabwe. And her question is COVID-19 has opened health workforce global markets, especially to developed countries where remuneration packages are better than developing countries. So, has Ethiopia faced any challenges on outmigration post COVID-19, and how has this challenge been addressed?
Yes, I believe that migration is inevitable. Uh, yes, professionals are, going outside country for a number of reasons. The big challenge we are facing these days is, tracking the data is a big challenge. But we are also facing this kind of issue, especially, post-COVID, the out migration is there. So, but what we are doing is we need to make in place a controlled migration, meaning is that we need to work with Ministry of Labor and Social Affairs, with Ministry of Foreign Affairs, so that we will have, a room to help, the migration process in a controlled manner. This is how we are working these days, but migration is inevitable and it's also challenging to any country in the world. Thank you.
Exactly. Thank you so much. I see Fusta has a question. So he has raised his hand. I don't know if you are in the interpretation booth, Asigit, because you might ask the question in French. But please go ahead, Fusta.
Oui, en effet, je vais poser ma question en
Yes,
français.
indeed, I'm going to speak French. This is a question that has to do with human resources. When I see the situation in Ethiopia in the 5 last year, they've increased the number of health personnel. But in my country, in the Congo, the situation is the contrary. We have too many human resources. And so our question is what we must do to get the right number of human resources in the health sector. Obviously, the first idea that comes to mind is to say, well, you have to stop training people, but that's not a solution which is politically acceptable, to stop giving basic training. In this Are there other countries who have the same problem as we do? In other words, where you have too many health workers, and how have those countries managed this issue?
That is a very good question. Maybe I think you could already answer on this, and then we have more room and space for other countries as well to share. What we wanted to do in this section is really go more in the clarification of what I think it has shared in his PowerPoint, and then leave it open for other countries as well to share on their experiences, their challenges, so that we can learn from each other. So maybe Asigit, you could already tackle this question first.
Thank you so much again. Thank you, Faustin, for raising this important question. Yes, the workforce production in most of the countries is very high. We are not, controlling the workforce production in a way to support the healthcare delivery system. So what I am, recommending is, harnessing the resource is very important, especially because, yes, we need many healthcare providers. Data from WHO and other, global or scientific communities shows that there is a critical workforce number in Africa, meaning that we need to harness resources to expand investments, especially in decent workforce employment and job creation, to realize the different commitments. The second important thing I would like to highlight is realigning workforce production capacity with needs and economic demand. We know the physical capacity of the country. Unless we realign the production capacity with the needs and demands, it might be very difficult, to go to make job creation, to make employment opportunities for the workforce. And the third thing, investing in workforce information, data, and evidence is very important. We don't have a mechanism to determine how many professionals are needed in the coming 10 years. So unless we invest in information, unless we invest in evidences, we will be, we will have a traditional mechanism. So it might be very difficult to control the production in a way, to achieve our goals and mission. So especially working on the health labor market analysis, working on workload and staffing need assessments are very important to alleviate some of the tackles in this area. Thank you.
Voilà, Faustin, j'espère que ça a répondu à ta question déjà.
Posta, I hope that you had a beginning of an answer to your question.
Hand it back over to other countries to share on Faustin's question. Are there any other clarification questions on the PowerPoint of Asigit? Good. But I'm sure some of the points that were mentioned will also come back in this discussion. So without further ado, I will hand it over back to you, Sarah, for this part of the discussion. What I will do as well is share some of the challenges, potential challenges that Asigit has shared in his PowerPoint in the chat box, so that it can really help us as well for this sharing of experiences, challenges, and this part of the discussion. But so over to you, Sarah.
Thank you, Amy, and thank you, Asigit, for this wonderful presentation. So now is the time to hear from our ALOs on their good practice and challenge. I will give the first one to Patron from Zimbabwe. Patron, the floor is yours.
Thank you very much, Dingisera. And let me also thank the presenter from Ethiopia for an excellent presentation to discuss issues around the health workforce. So I will share some reflections on the topic at hand, but focusing on multi-sectoral collaboration, given that it's one of the challenges that Ethiopia has highlighted, that whilst they have a good collaboration in place, but it's not up to the expected levels. And thank you, your presentation highlighted how the health workforce is a key building block, as given by the WHO framework on health systems strengthening. And there is a global health workforce strategy by WHO, which highlights that investments in HRH have shown a high return on investment, such that if you invest $1, you get a $10 return on investment. And a solid health workforce contributes to improved health outcomes, contributing to improved life expectancy. And in the same document, it actually stipulates that a 1-year increase in life expectancy is associated with a 4% increase in GDP of a country. And it's very critical for us to note that health workforce planning, whilst it is key, it's beyond the health sector. I am very happy that in the presentation from Ethiopia, they highlighted all the key stakeholders, and I think their list was very exhaustive. In my experience as a liaison officer in Zimbabwe, I have observed how multi-sectoral collaboration in health has progressed. So the government of Zimbabwe recently launched the Health Sector Coordination Framework. And in this framework, there are institutional governance structures that have been put in place to ensure multi-sectoral collaboration. So in the framework, we have the Health Sector Working Group, which is the country platform. So we don't have a GFF country platform, but the platform is within this health sector coordination framework. And under the health sector working group, we have a number of technical working groups, of which Human Resources for Health Technical Working Group is also a key element. This therefore allows for tasks in health workforce planning processes to be guided by the technical working group, right from evidence generation to strategy development and monitoring of implementation. So from the evidence generation, I'm happy Ethiopia was mentioning the issues around the health labor market analysis. So Zimbabwe also recently embarked on such an activity, and it was good to note that a task force was actually created from the HRH Technical Working Group, and it had all the relevant key stakeholders spanning from the Ministry of Health, other key government ministries, like Ministry of Finance. I'm sure we all know that payment of salaries is by the Treasury. The Civil Service Ministry in Zimbabwe, we have the Public Service, Labor and Social Welfare. Ministry of Higher and Tertiary Education. I'm sure you know that training of some health workers is beyond the health sector. Professional councils, regulatory bodies, and the private sector were also part of this evidence generation activity. For me, I noted this to be a best practice, because usually what ministries of health tends to do is to then approach the other stakeholders when their strategy has been developed. But having all these stakeholders coming to sit around the table right from evidence generation helps for the other key stakeholders to understand and appreciate the challenges within the health sector and the importance, and also even offer solutions and strategies that will be included in the HRH strategy document to address HRH challenges and issues. This therefore then helps in terms of ownership throughout the implementation phase. So in my view, having a documented framework for collaboration really helps, because it then stipulates how collaboration can then be done in an effective way, rather than creating parallel structures. And besides allowing for ownership from evidence generation right through to implementation, having this framework helps to ensure that the collaboration is done in a formal way rather than through a gentleman's agreement. I also want to acknowledge participation from our government focal point from the GFF. Dr. Kangwende, I see she is online, and thank you very much for participating. So this is the document, but I will share the link to the Ministry of Health website where the framework is in place. So having it formalized and stipulated helps in terms of improving the multi-sectoral collaboration. So that's my experience from Zimbabwe. Thank you, and over back to you, Dinksera.
Thank you, Patron, for sharing your country experiences in the process. I hope you finalize your strategy and get to share with us how the implementation is going on in the future. You mentioned very important points here, and I also like the WHO paper that you said, $1 investment in HR have a $10 investment return. Am I right, Patron?
Yes. So I will also share that. Yes, thank you.
Thank you. That was very exciting. And the other one is an evidence generation and strategic planning. You said the stakeholders were involved, and indeed multi-sectoral engagement for evidence generation to help understand the real challenge of the health sector is very important, and also gives us present ownership of the document. So thank you for that, Patron. And now I will move to Ambrose from Ivory Coast.
Ok, merci beaucoup, Dinska. Merci. Je voulais
Thank you,
d'abord
Dinksera. I'd like to thank the first two presenters. And I think there are many similarities between the development plan, the Ethiopian plan, and the Côte d'Ivoire development plan. I'd like to explain what we've done. The human resources problem is a real deep problem in Côte d'Ivoire, and the government has defined it as a priority. Various reforms were implemented. Among others, we have a health, human resources plan, which is being implemented by the Ministry of Health. The goal is to improve, from a quantity and quality point of view, the efficient use and the fair use of human resources in health. The health human resources have an important role to play regarding the reform which is underway in Côte d'Ivoire. It is a priority. It's one of the 7 priorities of the National Development Plan. I'm not going to give details because there is a huge similarity with the Ethiopian Human Resources Development Plan. In summary, we have 5 stages, 5 steps to reach the development of human resources, the rational use of those resources, and a whole strategy in order to retain the health personnel in what we call the silent regions. And there is also one stage, which is the development of data in human resources, health human resources. So it's quite similar to what Asegid has presented, so I'm not going to give you details. We wanted to involve the community. We have a community health department which tries to involve the community in the development of human resources in health. Aside from community resources, we have other stakeholders, the Minister of Health, among others, and the Minister of Plan, the Budget Ministry, Economy and Finances also intervenes, the Ministry of Education and of Higher Education. We have two education ministries, one for education and another one for higher education. And since medical studies depend on the higher education ministry, it has to be involved. The civil society is also involved in the territorial communities and, of course, the financial aspect. So we wish to involve the community, and we created a community development program which allows the community to intervene regarding development of human resources. Civil society shows that the community has owned the plan, and it intervenes also at the level of care, but also through a promotion of prevention, which is very important. The involvement of the community allows us to promote the prevention aspect in health. This leads to a better accountability. We feel it's essential, it's crucial to involve the community in the health personnel development. What are the opportunities this plan offers? Well, the community has a real role to play. It allows a better ownership by the community. There is a better offer and use of the basic health services, and it allows also a better involvement of all the stakeholders. But of course, we also have challenges, which are basically the same one as were mentioned regarding Ethiopia. The big challenge is the definition of community health worker. Another challenge is to reach a better coordination among all the decentralized health services. We need to improve the quality of the care. We have to improve motivation and retention of human resources and guarantee the sustainability of financing. This is, in a nutshell, what I wanted to share with you. Thank you.
Thank you, Ambrose. Thank you for your explanation of the somewhat similar strategic plan, the human resource strategic plan from your country. One of the, you have said so many important things, but one of the things that catch my mind were the community involvement and the community development program, which enabled you to have a good community engagement. And this could be a great example and experience for our country, as one of our challenges are weak community engagement. So thank you for sharing your experiences, Ambrose. Saying this, if anyone want to share their experiences or challenges with regard to the human resource section, the floor is open. For example, we can share, someone can share about Austin's question. He said that the problem is having too many health workers in the country, and what to do to balance the available job positions and the number of health professionals or graduates in the country. And I also see some questions in the chat box, but for some reason my mouse is not moving.
Yes, I see.
Can you help me out, Amy?
Yes, I'm here. So the questions have already been answered. I'm just translating them as they go. And so I see that Morbe has his hand raised up. So I think he has a question, and Ambroise as well again. So
great.
Yes.
Morbe, the floor is yours. Morbe, can you hear us?
Morbe, nous ne vous entendons pas.
Tu es peut-être encore sur mute, Morbe, si tu es en train de parler. Ah voilà, je vois que tu es déjà enlevé, mais
I think we can move to Ambrose,
yes.
And then
exactly.
We can come back to Morbe.
Ok, merci beaucoup, Dixera. En fait, ce n'est pas une question que je veux poser, c'est juste essayer d'apporter quelques
It's not a question I'd like to try and answer. I don't remember who asked that question. Faustin, yes. Regarding the number of health workers, they are lucky to have so many health workers because in many countries, the situation is the opposite. But as he said, politically speaking, it's not acceptable to stop training and educating future health workers. Maybe they could reduce the number of people trained. We know that every year you have a number of people who retire, and maybe the number of people who retire should be more than the number of people who are trained. And over the years, you could reach the right balance. In Côte d'Ivoire, we've seen that there is a limited number of students which are admitted to the medical schools. It's true also for the pharmacy school. But as regards nurses training, we have too few people. So we are trying to attract more people to the nursing schools. That's what I wanted to add. Thank you.
Thank you, Ambrose. Morbe? Morbe, your mic is on, but we can't hear you.
Maybe, Morbe, you can share it in the chat. It might be easier. Because unfortunately, your sound is not coming through. So if it's more comfortable, you can use the chat and we will address your question there. Yes, I think we can go to the next person in this case. You are muted, Sarah.
Yeah, sorry.
Yeah.
Okay, so maybe I would like to add a few takes on Faustin's questions. I remember, and also Asagid could also tune in if you know, if he likes. So I remember there was this steering committee that was established to oversee the unemployment of the health workers in Ethiopia. Not that we have so many health workers, but the unemployment rate was going down. So this steering committee was established. And of the solutions that they proposed, one was updating the health facility staffing norm by considering the input from the workload indicator of staffing need, and also the health labor market analysis, if that's has been done in your country, and advocate to increase the health financing and recruitment from the government and to the regional states. And also the other was revising the the regulatory standards of the private health sector. So, you know, to attract more private health sectors in the investment, so the job creation will increase. And also to building of the public-private partnership. So, you know, some of the examples that were mentioned was office practice or medical group practice, or creating home-based cares. So this is something that as professionals would have to work with the public, so they could create their the job for themselves. The other one is establishing foreign employment platform. I know the brain drainage or the migration of health workers were mentioned, but if you truly believe that there are enough health workers in your country and the unemployment rate is going up, and then this is an opportunity to establish the foreign employment platforms. This is what I have. I will, if Asagid want to add, I'll give the floor to you. If not, Patron.
I actually wanted to also add to what you have just said, Dingisera. Maybe for Faustin, we may need to know, for your country, you said you have many health workers who are not employed. So the question is, your health worker to population ratio, is it within the recommended norms? Because we know there are international standards to say for such and such a population, you need to have so many health workers. So if you realize then that your health worker to population ratio is below the recommended standards, what it might then be implying is you have a surplus in the market, but of course you have scarcity because you have not yet reached the recommended norms, perhaps for universal health coverage. So the issue would then be to lobby for additional expansion of your establishment within the public sector so that at least you get to the recommended norms. That's what I wanted to add. Thank you.
Thank you, Patron. I see there are so many comments and questions in the chat box.
I also think that Asagid wants to react maybe on some
great,
that you
great.
shared. Yes.
Asagid.
Thank you so much, Sarah. I would like, to populate on some of the points you raised. On the HRH steering committee, what I would like to say is, since HRH challenges are, complex, and health workforce actors are multiple. So collaborative partnership is very important to advance HRH goals. So for this to happen, we have actually established HRH steering committee, which will, review the overarching HRH goals. They will determine cross-sectoral HRH challenges and develop, policy recommendations that will be implemented to advance HRH in our country. So we are, seriously working with different actors in this regard: the Ministry of Health, the partners, the professional associations, and the universities are part of this steering committee. So they are, they will have, a role to, review the overarching HRH course. That's what we are, working in HRH steering committee. The second thing on the models that's used to advance employment opportunities in our country. Yes, unemployment is, one of the priority agendas. So we have made different kinds of consultation with different stakeholders. So based on the different discourses and inputs made, recognizing the urgency of, this problem, we have endorsed various recommendations. So, the first one is, revising the facility standard, because our facility standard is very tough to achieve. A novice healthcare provider will not attain, the requirements to start service by themselves. So what we did was we have designed a model called solo and group office medical practice. So this helps to provide opportunity for efficient, quality, and patient-centered care. When we design this solo and group practice, a novice healthcare provider can set up a clinic with a minimum cost, but and with minimum standards. But when we designed these standards, we were very, curious that all these issues are, better adhere to national guidelines. We have also made criteria in place to provide, patient-centered care and others. So this, inspires many healthcare providers to see, something different, that they can work, they can create a job by, themselves without waiting the recruitment by public or private facilities. This is from my side. Thank you so much.
Thank you, Asagid. I see a lot of question and answers in the chat. Amy has kindly made an interpretation of the French comments. Thank you, Amy. So let's move to the other challenge, the potential challenge that Asagid previously mentioned. Amy has put it in the chat box. If any one of you have any comment on those challenges, you're welcome. Okay. So thank you for this wonderful sharing of experiences. So I'll give the floor back. Oh, Ambrose, sorry, you can go ahead, Ambrose.
Okay, merci, Dinksera.
Thank you, Dinksera. In fact, as I said, there's a lot of aspects common with Côte d'Ivoire when it comes to these challenges. And I see that you talk of ongoing or adult education. That's important for us. We have an Office of Training and Research for Health, which is in charge of ongoing education, adult education, and there are training courses, sometimes by video. And so it's possible to continue to train the people, the medical personnel in the country. And so I wanted to tell you this because this is the experience of Côte d'Ivoire, and it can be useful for others. Thank you.
Thank you, Ambrose. Indeed, in-service and out-service training of health workers is very important. So thank you for sharing. Anyone else? So Amy, I give it back to you.
Yes, that sounds great. Thank you so much. Thanks, Sarah. Good. First of all, I would like to give a warm thank you to Assigate for his wonderful presentation. Thank you to you, Ding Sarah, for your wonderful facilitation as well. Thank you to Ambroise and Patron for sharing as well from their country perspective. And thank you to you for joining us today. I just want to mention that this webinar is part of the knowledge and learning support, and you may expect more webinars of this kind in the future. And it's also part of the peer learning from the GFF on the broader HRSR discussion. So what I can say for now is that stakeholders will be informed about further developments. So the recording as well and the PowerPoints will be available on the Knowledge and Learning portal. And then I will also like to thank the interpreters and Victor, our colleague, for his logistical support. Thank you all for joining, sharing your challenges and good practice. And I hope to see you once again in a new webinar. Thank you and have a wonderful day.
Thank you. Bye.
Thank
Bye,
you.
Thank you so
everyone.
much. Have a nice time.
Bye.
Bye.
Bye-bye.
Ok, merci. Au revoir tout le monde.
Bye.
Bye.
Bye. Thank you.
Bye-bye. Thank you.
Bye-bye.
Bye-bye.
Bye. Thank you.
All right. Thank you so much, Victor.
Okay.
Have a wonderful day.
You
Yes,
going back
thank
to
you.
sleep.
Back to have a good rest.
Okay.
Bye-bye.
Bye-bye.
Bye-bye.